the one thing we do have in common, though, is that the land we're on always hasn't been and always will be Aboriginal land. So I'd like to pay my respect to elders past and present, and I welcome any First Nations people to the forum today. So by brief introduction about myself, if you weren't here last week and don't know, my name's Amy Coops. I'm a recently or about to graduate doctor, so I'm sort of a non-medical student, but I start working as a junior doctor next year with the Victorian Rural Generalist Program. I live out in Albury with my partner and our 2 children, and I've got a passion for LGBT QI health, and I'm really excited about being able to start working and bringing my passion for those topics. And, you know, being a visible queer person in a rural community, I'm really happy and looking forward to having the opportunity to kind of bring my passion to the fore when I start working. So just in terms of a content warning, of course, tonight we'll be talking about LBQ women's health, and you may find some topics and findings confronting. So I encourage you to take care of yourself. And if that means you need to mute or walk away from the computer for a minute, please feel free to do so. That's completely okay. And also the email you received with the forum link will have some places to go if you need support after these forums, and please do check in with us if you need. So firstly, on the structure of tonight, we'll be hearing from SWASH researchers, Julie and Rachel, and they'll be talking about some of the findings from SWASH in terms of healthcare screening, gender and sexuality in healthcare. And then we'll be having a Q&A with our panelists, who I shall introduce imminently. First, in terms of housekeeping, before I do that, if you do have a question for the researchers, and we'd love it if you would bring some questions in, it'll keep the panel quite lively. Please, we'll save them to the end, and if you can pop them into, there's a little box down the bottom that says Q&A, so feel free to chat in the chat with each other, and that's great. And if you forget and you accidentally put your question in the chat, that's fine, we'll migrate it across to the Q&A, but if you can use the Q&A, that would be really great. And if you're a Twitter person, please keep the conversation going over there using the hashtag SWASH, and you can follow that hashtag as well. And just a reminder, this session is being recorded. So I'm just going to start off by introducing our 2 researchers who will be talking, giving us a brief snapshot of the SWASH findings. So we have Julie Mooney-Summers, who's an Associate Professor at Sydney Health Ethics at the University of Sydney. Her research focuses on the health of sexually and gender diverse people, primarily related to tobacco, alcohol and other substance use. And she will be joined by Rachel Deacon, who is a research associate with South Eastern Sydney Local Health District and the Faculty of Medicine and Health at the University of Sydney. She's an experienced clinical researcher in the drug and alcohol field with other vulnerable populations. In collaboration with ACON, Julie and Rachel lead the longest running periodic survey of lesbian, bisexual and queer women's health, SWASH, and I will now hand over to them to take it away. Thank you, Julie and Rachel.
Thanks very much, Amy. I'd also like to acknowledge the traditional owners of the land that I'm on and that SWASH has taken place on. So it's the Gadigal, the Gadigal people of the Eora Nation, who are also the traditional knowledge holders and have been part of the SWASH survey from the very beginning. So we are going to talk about SWASH. I'm not sure how many people who are here today were here at last week's session, so I'm just going to give you a very brief overview of SWASH and then we'll launch in quite quickly. So SWASH is definitely the longest running, possibly the only, certainly the most comprehensive regular survey of lesbian, bisexual, queer and other non-heterosexual women's health in the world. So whatever way you want to think about it, we know quite a lot, although as it turns out we need to know a lot more, but we know quite a lot about the health and well-being of LBQ women in Sydney. We talked in quite a bit of detail last time about how we generate the data, so I just want to say as a quick reminder that most of the data is generated through in-person data collection. So we have a paper survey that we give to people at Mardi Gras events. And then a smaller online survey that happened once Mardi Gras had finished. The survey is aimed at women, so cis and transgender women who identify as LBQ or otherwise not heterosexual. We do also have a proportion of the sample identifies as non-binary, and we talked a bit about that last week and happy to talk a bit more about that, but I won't, not formally. Today we want to talk about healthcare use, access and experience. I'm going to talk about screening and Rachel is going to talk about healthcare interaction. As Amy said, if you've got questions, please pop them in the Q&A. So I'll hand over to Rachel to talk about who participates in SWASH this year. I'm sorry, Rachel, you're on mute. I hate to say it.
Zoom 101. Okay. Who participates in SWASH? So first of all, looking at sort of the numbers of participants that we get and the age groups into which they fall. We had a bumper year this year. We had the most surveys ever, 1,588 people participated. You can see by the orange bars, they're higher than all of the other ones. And the age group that we usually get the most responses from is the 25 to 34-year-old age group. And looking at some other basic demographics, in general, this is quite a highly educated group. There's fairly low unemployment, fairly good incomes for a lot of people. And 15% of people have dependent kids. 1% this year identified or are intersex, and 4% are Aboriginal or Torres Strait Islander. And other cultural mixes are relatively similar to what we see in New South Wales population surveys. Where people live, this survey, nearly half of the people live in the sort of broad inner west and city area of Sydney, with smaller proportions in the other greater areas of Sydney, and about 8% of people who reside outside Sydney. Launching into some healthcare findings. Actually, sorry, I'm going to switch back to Julie.
Thanks, Rachel. So I'm going to talk about screening. So the first thing we're going to talk about is mammography. And for those of you who don't know, Breast Screen New South Wales recommends a mammogram to screen for breast cancer every 2 years for 50 to 70-year-old cisgender women. And for gender diverse people assigned female at birth who've not had gender affirming top surgery, and for gender diverse people assigned male at birth who have been using gender affirming hormones for 5 or more years. So it's some complex guidelines there, but generally we're looking at the 50 to 74-year-old participants in SWASH. So the important thing here to notice is, in general, on these slides, green is good and red is bad, or red is the worst. So what we see here is that 21% of the participants were overdue for screening or had never been screened, or we're not sure if they'd been screened. So you see the red there, the bulk of them are the never, not sure, not screened, and then the rest of them are people who are overdue. New South Wales Health publishes a 2-year screening rate for women in New South Wales who are age 50 to 69, and the screening rate in New South Wales is 51%, and among SWASH it's 69%. Which looks awesome, yay for us. But it's really important to remember that SWASH sample is highly urbanized, highly educated, high income, less ethnically diverse. So all kinds of things that we know can be relevant characteristics in terms of access to mammography. It's also younger. So although we have a range in terms of 50 to 74, in SWASH they're tending much more towards the 50-year-old age group. So that might be relevant in terms of making those comparisons. All right, next one. Thank you, Rachel. Bowel screening. So this is a new question for us in 2020. And again, for those of you who don't know, the National Bowel Cancer Screening Program recommends everyone is screened for bowel cancer starting on their 50th birthday and then every 2 years until they turn 74. You get a package in the mail where you give a sample, which you then send off. So for both mammography and bowel screening, it's important to realize that these are things that you don't have to interact with a GP to get access to. So they're particular kinds of screening in that way. So 34% were overdue. So that means that they were screened more than 3 years ago, never or weren't sure. So slightly higher than we saw in the mammography. it's important to look, if you notice there, the red part of the donut, that among the 22% who'd never been screened, most of those people had got a test at home kit but hadn't returned it, which is a really nice, clear opportunity for messaging and health promotion in terms of engaging. If we look at National Bowel Screening Programme data on 2-year screening rate, 41% of women nationally had screened, and that compares to 58% in SWASH. So again, it looks pretty good, but all of the things I said before all still apply. Highly urbanized, highly educated, less ethnically diverse, and also younger. One of the things we looked at additionally is when we think about mammography and bowel screening, they're all being directed at the same age group. So we were interested to look at, were there people who were doing neither? So what we actually found was that 70% of people in the SWASH sample, aged 50 to 74, had done both, which is pretty good. And there was only 4% who'd not had mammography or bowel screening. So that's a very small proportion with all the caveats, but I think that that's still a relatively good news story. Next one, Rachel, thank you. So cervical screening, lots of you will know that the cervical screening program changed a couple of years ago in Australia. So we now screen from age 24, or something ridiculous like 24 and 8 months, but let's say 24. Up until the age of 74, we are now encouraged to screen every 5 years, and the test is now looking for HPV, whereas we used to be doing something called pap smear, and it started earlier and it happened every 2 years. This makes things quite complicated in terms of being able to monitor screening and look at changes over time. In Australia, we're not currently able to access screening data for the national picture, because they're not going to produce that data until they have 5 years worth of data. So what we've decided to do is we will just look at our data under the old rules. So we're being really clear about that, but it gives us a sense of whether things are changing or not. So it's probably another 2 years or so before we're going to be able to look at under the new program. So under the old program, so this is starting at 18 years old and doing it every 2 years, 37% were overdue or had never had a cervical screen. And we've got data going back quite a long way, and that's pretty consistent finding, so nothing much has changed there. We were interested to know what is the most important things in terms of working out who is screening and who's not. And we've consistently found that the most significant predictor of screening is whether the participant in SWASH had ever had sex with a man. So if you look here, green means someone is up to date, and you can see that on the right hand side, if they'd ever had sex with a man, they're much more likely to be up to date. Red means never screened at all, and again you'll see that nearly 40% of people who'd never had sex with a man had never had a cervical screen. So that's clearly a concern and is not at all what the medical advice is, which is that everybody just needs to have one. So it's clear that we've got something important to address there, and that's a very consistent finding for us. So we flick to the next one, STI testing. Now, STI testing is different to the other things I've just talked about because we don't actually have a clear point that we're aiming for. So are we looking to have everybody screened regularly, every 6 months, every 12 months? The national advice for the general population, which I think generally means heterosexual, is to be screened every year. There aren't any guidelines around LBQ women's screening, but we do know that some STIs have no symptoms, so we shouldn't just be getting a test when we have symptoms. We need to be screening regularly. Having said that, what we do know is 39% of the sample had never had an STI screen ever. Again, if we look at what the important characteristics are, then it is still about never had sex with a man. So if you'd never had sex with a man, you're very unlikely to have had recent STI testing and pretty unlikely to have ever been tested at all. So you'll see there about 60% of the sample who never had sex with a man had never had an STI test. We don't have any comparable data, so I can't tell you if this particular sample is like other samples, but that's pretty important to notice that those two particular things are important in terms of ever and never having had sex with a man. The other thing we know is that about 24% of people who'd been tested had ever had an STI diagnosis. So it's not that the testing is not necessary. It clearly is. We don't know what STIs they were diagnosed with, and maybe Viv or Liz can talk about the kinds of STIs that come up in the clinics at ACON. And as you'd expect, that if you'd had an STI diagnosis, you were more likely to have had a history of sex with men, because you're more likely to have been tested. And we've done some analysis in the past where we've looked at kind of thinking about what might be going on here in terms of a healthcare setting where people who are attending for healthcare, are they being offered STI testing and cervical screens? Who is more likely to be offered? And it's possible that maybe the women in the sample who never have sex with a man, maybe their GP knows that or makes assumptions, or the woman herself is making assumptions and so is not asking for testing. If you flick to the next slide, Rachel. So we looked at this. So in terms of STI screening and cervical screening among the over 22, so this is people who are definitely eligible for cervical screening. So 10% had never had a cervical screen or an STI test, so much higher than that older age group in terms of bowel screening and mammography. And when we look at what characteristics are relevant here, we see that the people who've never had either of those two things were more likely to reside in Western and Northern Sydney, less likely to have a regular GP, less likely to be out to their GP, and less satisfied with their GP. And I think there's a whole bunch of things that are really important there for us to pay attention to. So what it says to me is they're more likely to be in a place where they might be less confident that they're going to have a culturally safe GP, that maybe they don't have a regular relationship with a GP because they're not feeling safe to have a regular relationship. If they're not having a regular GP, they're less likely to be asked for those kinds of routine things because they're only going to the GP when they have a particular medical issue to raise. So there's a whole bunch of things that I think are really important there to think in terms of the younger SWASH participants. I will hand back to Rachel.
Okay, thank you, Julie. So I'm going to move on to PrEP awareness, access, and condomless sex. So the PrEP or pre-exposure prophylaxis is various medications available to take for people to reduce their risk of getting the HIV virus, and it's been available the last several years. In the 2020 survey, we asked about PrEP awareness, whether people had heard of it, and we did find that about 2/3 of women answering the survey had ever heard about PrEP. And we also asked about whether they'd tried to access PrEP and whether that was successful. 4 respondents said they had tried and failed to access PrEP, and 9 had been successful. And all 9 of those did report recent condomless sex, which is one of the indicators for being prescribed PrEP. When we then had a look at one of the particular risk factors where people are having sex with men who have sex with men, what this graph here represents is we've got in here women who've said they've had recent sex with men who have sex with men, which is around 9% to 8% of the whole sample, and that's been quite consistent over the years. And then the different colours are indicating have they reported condomless sex, and that's penis vagina or penis anus condomless sex, amongst the group that's having recent sex with men who have sex with men. And we can see there's quite a big jump between 2016, 2018, and even a little increase in 2020, where people have reported that they're not always using condoms when they're having sex. And we're theorising that this might be around now that PrEP has been available for some time, that we don't know from the survey the context of this sex. A lot of it is probably with regular partners where people have safe sex agreements, monogamous partnerships and so forth. But certainly, this increase in condomless sex we do think is linked to the availability of PrEP. And as it is a risk for HIV, is worth us turning a little bit of attention to. I'll just note that in 2020, that's the first year we've asked about access to PrEP. Of those that did report condomless sex and had sex with men, tongue twister, 5 in this group had tried to access PrEP and 4 were successful. So indicating that women are starting to access this. We don't understand yet. Similarly to STI tests, we don't have a specific rule or indicator of what's good access to PrEP, or as I said previously, we don't understand all the nuances of people's relationships with this. But this is one area that is worth keeping an eye on, and perhaps trying to, advocate for healthcare that could help people. Then moving on to, are healthcare providers respecting people's sexuality and gender identity? So this year we asked a new question where we asked, was your sexuality or gender identity respected at your last healthcare interaction? And we also asked people to specify what sort of healthcare they had gone to. So we found that these were the top 4 types of healthcare that people had indicated they had last been to, with going to a GP or a medical centre being the most frequented one. And the green indicates here that people felt very or somewhat satisfied that the providers in that interaction respected their sexuality or gender identity. Red indicates that they were somewhat or very unsatisfied. The blue bar, the light blue bar, indicates that sexuality or gender identity wasn't relevant, or the respondents didn't think it was relevant in that interaction. And only about 10% of people said that it was not relevant for them in that interaction. Looking at the differences between the different types of healthcare that people had last been to, there are some differences in the level of respect that people felt. With people who'd been to a sexual or reproductive health service last, note that there's no light blue bar at all. No one who'd been to that type of service thought that their sexuality or gender identity was not relevant to that type of service. And then people who'd been to a medical specialist, a much larger proportion, around 20% there, indicated that sexuality or gender identity wasn't relevant, and the satisfaction levels were somewhat lower than with the other types of healthcare. So medical specialists are often quite a different sort of interaction to the other sorts of healthcare. They're often once off, quite short. You don't get to develop often a relationship with the person that you're seeing. So perhaps this has some bearing on the results that we see here. And then finally, we looked at GP access and how satisfied people were with their GPs. Sort of first port of call doctors. And we asked about satisfaction and also asked whether people were out to their GPs, if they had regular GPs or not. And when we have a look at how satisfied people with their regular GP, if they were not out to them, we find that around a third were very satisfied, another third satisfied, and perhaps under another third were people who were not satisfied, and just very small numbers there who did not report. Then we contrast that with satisfaction levels when people are out to their doctors, and very satisfied and satisfied are yeah, they're like 90% of the people who were out to their regular doctors. And this, really indicates that where you do have a relationship with your GP, where you can be out to them, it really increases the levels of satisfaction, and then we surmise, health, the healthcare provision, we hope would be much better as well. I just note in these circles, these are not the entire sample. About 18% of participants in 2020 did not have a regular doctor, so they aren't included in these charts here. So that brings us to the end of the presentation, and just showing the link here where the full SWASH 2020 report can be accessed on ACON's website. And we invite you, if you're not already got it in your calendar, to come to the last forum next Wednesday on alcohol and drug use. The link to register for that will be popped into the chat box, and you'll be able to register via that.
Fantastic. Thank you so much, Julie and Rachel, for that quick whiz through the data. So we're going to move on to the panel discussion section of the event now. So I'm just going to quickly introduce our panelists. And obviously Julie and Rachel are going to be here as well. So these are our extra special guest stars. So Karen Price has over 20 years experience in senior health roles across HIV and sexual health, mental health, drug and alcohol, and aged care sectors. Karen has been with ACON for 7 years and is the Deputy CEO, and has led key developments for ACON, including the establishment of our ATEST services, expansion in ACON's work with women, and the establishment of a multi-year partnership with the Cancer Institute of New South Wales. Since 2018, Karen led the advocacy for and secured an election commitment from the New South Wales government to explore the feasibility of establishing a health centre that specialises in healthcare for sexuality and gender diverse people in New South Wales. Currently, she is leading the development of the feasibility study for the centre, the vision for which is to provide excellence in community-led, person-centred and integrated healthcare for our communities. We also have Viv McGregor, who's worked at ACON for over 6 years, primarily in queer women's sexual health. She's now the ACON coordinator of Checkout, LGBTIQ+ sexual health clinic. Checkout is a peer-led service run in partnership with Family Planning New South Wales and provides HIV, STI testing and or cervical screening to all sexuality and gender diverse people and sex workers. And finally, writer, photographer, sexual health nerd, filmmaker, pan aficionado, podcaster, occasional musician, bumblebee enthusiast, and ex-roadie, Liz Duck Chong is a true Renaissance figure in the sense that most of them were really gay. Liz is the peer coordinator at Trans Test and a peer at Checkout. And just finally on ACON, ACON is a fiercely proud community-based organisation running a range of services, including the aforementioned sexual health screening and testing services, ATEST, Trans Test and Checkout. I will now hand over to our panel guests to explain in more depth their roles and ACON services.
Thank you for that introduction.
Thank you.
I might kick off, Amy. Thank you very much to Julie and Rachel for their excellent presentation, and for those that were here last week on top of the excellent presentation last week. But please check out SWASH. It's got so much information in it. You'll be glad you did. Look, ACON's very, I think, fortunate, incredibly fortunate actually, to have a long-running partnership such as this, and SWASH has got a unique place for ACON, both as a long-standing partnership now at the University of Sydney, but also because it's allowed us to do significant advocacy. It's allowed us to develop services, and it's allowed us, I think, to have to develop and really kind of take forward some important work. And check that I'll leave to others to talk about. So just a couple of things from my perspective. I'm fortunate enough to sit with Julie on an advisory group who are working with New South Wales Ministry of Health at the moment on the state's first LGBTIQ, it's currently called, health strategy. So New South Wales has not had a health strategy for our communities before. And it's been a long process. It's taken over a year so far, and we still don't have a draft, but I can tell you that there's been significant backwards and forwards with the ministry based on the needs analysis that underpins the strategy. And I can tell you also that SWASH is pretty much one of the very few data set and evidence bases upon which we have spoken about local women's health issues. There are some international data, and those references exist, but there is such a gap. And we know that from our work, but also I'm sure anyone, Amy's just gone through medical school, and the lack of education and training and information really about inclusive healthcare for our communities, particularly for LGBTQ women. Quite a bit of focus on HIV and gay men, obviously, but aside from that, there's a real gap. So our work in advocacy, ACON's advocacy work, is really critical, and SWASH really underpins quite a lot of that. Off the back of the SWASH data over time, and also our ability to ask new questions within SWASH, we've been able to inform our 3-year multi-year partnership with the South Wales Cancer Institute, and previous campaigns and funding before that. So we've been able to run campaigns like the Inner Circle, which has been focused on cervical screening for anybody with a cervix, the United Front campaign around breast and chest cancer screening, and inclusion of our communities in that space. But quickly, and before I kind of wrap up, I suppose my bio I kind of tweaked to talk about the health centre, because the health centre was an election commitment we secured off the back of, again, quite a lot of advocacy, which SWASH was important for. It was also off the back of our experiences when ACON establishes a health service that's designed specifically for our communities, and we engage and involve our peers in that situation, in the client service delivery, be it a test, which is designed for gay men and other men who have sex with men largely, or checkout, or any other kind of service where we have peer leadership and community-based kind of values underpinning it. We have an enormous response from our communities. The service is usually booked out within minutes and oversubscribed for time, for some time ahead. A-Test has become the second biggest sexual health testing service in the state within 4 years, and that's saying something, because they've been around since 1985 in about 26 locations across New South Wales in the form of local health district sexual health clinics. So within 4 years, our communities have voted with their feet. And particularly within A-Test Oxford Street, there's 5 or 6 places you can get a HIV test for free if you're a gay man within 2-kilometre radius of A-Test. They come to us for a particular reason. Our client satisfaction ratings are 95% to 100%, and it's a really popular service. So it matters when people are understood. It matters when people are met with a non-judgmental attitude by people who understand, and there is a different quality of the conversation which aids in better healthcare. And Viv and Liz can expand on some of those things, but it's been an enormous experience, and the health centre hopefully will take it forward.
Yeah, so Viv and or Liz, not sure between you who'd like to go first, but if you'd like to give a brief kind of snapshot of what it is that you do, your services do, and at your service what you yourself do.
Yeah, for sure. I'll go first because it makes sense in terms of how I'm looking at the screen. So I am the ACON coordinator of Checkout, which is open to all sexuality and gender diverse people and sex workers for cervical screening and or HIV STI screening. And we are kind of built on a similar model to A-Test, which is a peer-led service. And that means when you come into our clinic, your main point of contact, your first point of contact is with a peer worker. So that is an LGBTQ plus community member who we've trained up in cervical screening information, sexual health, and they're your first point of contact in terms of making it a welcoming, non-judgmental, less intimidating space. Obviously, that's contributed to by hanging a lot of flamingo fairy lights in the space as well. As we all know, that is our verge. So having that kind of welcoming environment that's like explicitly not just a rainbow flag sticker, but is like, there will be gayness everywhere, has been really important and effective in terms of the feedback we get from clients about what it's like to walk into a space that has, someone wrote in the comments, some of the peers were too attractive and it was intimidating, and I'm like, best critical feedback ever. I can do nothing about that. They're very beautiful. But otherwise, like, most people find it a really welcoming space. And that peer worker does a consult with our clients, talks them through what happens in a sexual health screening, what their rights are, the kind of questions the nurse is going to ask them. And we've worked really closely with family planning to develop a sexual history script that suits our communities. There's a kind of basic sexual history taking that if you're a GP, you just like look it up and read a couple of questions, and it's all very heteronormative. or focused on gay men and, you know, a kind of cisgendered understanding of gay men's sexual practices. So we worked with family planning nurses to rewrite it and include questions like, you know, are you using gloves when you have sex, you know, that involves your hands? Are you, you know, having like oral sex on people with a penis, people with a vulva? Like, it's all very, you know, detailed and parts based. So we focus on a parts and practices model. So body parts don't have genders, people do. So when we're talking about STI and HIV risk, it's really important to talk about body parts and practices. And yeah, we've had really amazing feedback about the service and a really diverse range of clients as well. Our main clients are cisgendered women, but that's followed quite closely by non-binary people, and then a range of others. And I think, yeah, most predominantly we're seeing people who identify as queer, people who identify as pan and bisexual coming through the service, which is really great, especially considering bisexual people have really low health outcomes and low testing rates as well. So yeah, that's my job, is pretty much to coordinate the peers and to liaise with Family Planning New South Wales. I don't know why I can't say liaise like a normal person, but it's always really gay when I say liaise. And yeah, Liz is actually one of my peers, and then she was poached / we have shared custody with Trans Test. So if Liz wants to talk about Trans Test.
Yeah, absolutely. So yeah, I'm one of the peer workers at checkout, and so I do all of those various processes and comforting bits and pieces, welcomings and things like that we've talked about. And then we kind of took that model, and that was also kind of shared with A-Test, and then developed that into Trans Test, which was a clinic that unfortunately we've only actually been able to have several several months open from, because we started earlier this year, and then this year happened to all of us, and so we're hoping to get that back on the road soon. But so that's just a small temporary little moment in the middle of what I hope is a long career for Trans Test. But it's the very same idea. You come in and you see a trans and gender diverse peer who talks you through what to expect at the service, helps you if you're feeling anxious or uncomfortable, or, you know, we have data from a range of sources that trans and gender diverse people, like the wider queer community, do have difficult experiences with doctors and are often not heard, not understood, not believed, or even just ignored in their needs and their wants. And so having someone kind of there to help advocate for you, which is how all of these peer model clinics work, allows you to kind of have that stress taken out of it, because someone is immediately there on your team. And ideally, everyone in a health system should be on your team. But if the people that have the power are not, having people to stand with you and help get them on your side takes that effort away from you and takes that kind of onus away from you. And so that's really the role of peers, is to be, you know, your co-pilot, to make sure that you're being well looked after. And so that's my job in these clinics, is basically to make sure people feel comfortable and feel welcome. But it goes back to what you were saying before, Karen, around the idea of people being heard and being seen. And that's why things like SWASH and why these clinics are so important, is, you know, we use models like parts and practices, which are very important ways of talking about health information and kind of bodies and interactions. But the reason these clinics are so successful, and the reason that ACON broadly is so successful, is we also care about the people. We care about the individuals, and it's not your body parts, it's not your genitals, it's not what you're presumed at birth, it's none of those things. It's a combination of that and so much more. And we care about the individuals, and that's how you provide valuable healthcare. And that's, I think, why SWASH has also been able to be so successful for so long. It's because it seems to really care about the people.
Yeah, I'd be interested to ask, for those of you who do work in clinics who provide peer consults, how are the peers received by the clients, and how does the interaction work between the peers and clinical staff and nurses?
Sure. In terms of, well, I have worked in the clinic as a peer, but because I'm the coordinator, that tends to pull me out of the clinic. But we've all agreed that due to my high levels of sarcasm, that it's not a bad idea to pull me out of client-facing and just get me to, I'm very good at identifying like emotionally intelligent people to hire. So that's my job. And then it's like, if Viv's not nice enough, put her in the office.
You need to hire some emotional teddy bears.
I do. Yeah, I really, really do. Anyway, still have a valuable role. And part of that has been working with family planning. So working out exactly what role and responsibility a peer worker has in a clinical setting is a real challenge, because there's legal issues to consider that kind of have to take precedence around medical practice. But then there's the more complex, nuanced spaces around peer workers who are not they're not clinicians, they're not medical practitioners, giving what would constitute medical advice. So peer workers being very careful to we are providing information. That's what we're doing. And when we're asked questions by clients, there's obviously some questions we can answer because they are, factual, but questions around, do you think I should get this test, for example? All my peers are trained so well to answer but pivot at the same time and go, first of all, it's entirely up to you and what you're comfortable with. Here are some of the reasons people would get that test. Like, here are some of the sexual practices that might mean you need a throat swab, or it's a good idea to talk to the nurse about getting a throat swab. But the peers can't say, yeah, you need one because you've been doing these things. Like, that's not their role. So we had a lot of consultation with family planning about getting the peer role, right, because the peers need to be, as Liz mentioned, an advocate, which means they do need to have, I don't want to say authority because they don't have authority over the client. It's very collaborative. Our entire service is built it's a trauma-informed service from the ground up in every single thing that we do. Most trauma-informed practice is based on understanding that you have a traumatized patient coming in and then you employ trauma-informed care. We employ trauma-informed care across the board because too many people in our communities have experienced interpersonal trauma, discrimination, trauma within medical settings, trauma inflicted by medical practitioners, that giving trauma-informed care to everybody, even if they're not traumatized, it will do them no harm. They might actually feel really cared for. That's what trauma-informed care is about: collaboration, care, agency, So my peers need to have, I'm calling them my peers, just removing their agency. They don't need it. So they need to have authority around the information they're giving, that balance between, I'm absolutely a source of information for you, like a culturally appropriate in terms of queer sexual health source of information, but I can't tell you, yes, you definitely need an anal swab today. So that's been really interesting. But the main, sort of thing we take away from that process of working this out with family planning was the relationship between the peers and the nurse has to be collaborative as well. And that's been really encouraging to see that when it works, when nurses learn from the peers and the peers learn from the nurses, because peers aren't just trained, they bring life experience, and we do have a really diverse staff that I jokingly refer to as an ARC, because I'm aiming to have 2 of every kind of queer, and we will get there eventually. But that's really important knowledge, like our experiences as staff with medical practice, our experiences with sex and sexuality, with gender identity. These are important to bring into a clinical space, and to have nurses be receptive to that has been incredible to watch. And our feedback is really good around that stuff.
And just to add to that, Amy, and thank you, Viv, that was perfect, and absolutely mirrors exactly what we get told from both nurses and also our clients about the difference. But just to take it into a kind of a more sort of a different level, I suppose, one of the biggest challenges is trying to explain to a mainstream health provider why they're not inclusive, and what the data shows when you are inclusive, and the eye-opening moment that is, the aha moment that goes on when they do realise they can learn something from a peer, and that life experience and all of the things that Viv just said make a quality and a real difference to the way that healthcare is received, the exchange of information that happens, the possibility of referrals and more comprehensive healthcare. So the first trick is to really kind of have some sort of information to use actually explain to the healthcare provider, and in this case, sometimes our partners, like if we came to family planning needing a partner for this service, family planning provided a lot of cervical screening to people in our community. So we kind of went, oh, well, let's partner with you. But that conversation, you shouldn't ever assume, I think that conversation is going to be a simple one, because you're basically telling them you're not that great at doing this for us. And that's a not easy pill to swallow for some people. Then sometimes if you get rostered on a nurse that's one of those examples of not great for us, that conversation is also quite difficult, because we are very, very fierce around the safe place that checkout and a test and all of our services are. So one way of dealing with that, and Viv worked really hard with this, is to make sure that we have a robust accreditation program, not just for the nurse, not just for the peers, but for the nurse as well. This is what the accreditation looks like for us. We're going to also make sure that you're actually informed and trained around some things you don't know enough about yet for us and for our comfort. So it's a two-way street, and that is interaction, lifting that up again, I suppose, to a health sector level when we're trying to advocate to the government to actually create a new health service for our communities more broadly, is again that argument about, well, why do we need special service? They can go to a local health district or a GP clinic just like everybody else. What's the special and different thing that we're missing out on here? And that's actually a tougher conversation than it should be, because the state doesn't collect our data, neither do GP clinics. It's not reported on widely. So that gap between the experience of care, and while SWASH says that a lot of people are fairly satisfied with their GPs, when they actually feel the difference of actually going to an LGBTQ specific service, they realise the gap is actually quite big, and that conversation is a whole new thing.
Yeah.
One last thing.
I was just going to say that's absolutely reflected in our feedback, that they thought they had a okay doctor, and they were like, I never knew how this would feel, like coming into an expensive space.
One last thing, in our advocacy, and we've, as I said before, we've got our election commitment. We're working on the feasibility study for a very big venture in terms of integrated care for our communities with a GP clinic at its heart. We did a survey of our communities broadly, and it was 570 or so respondents. A lot of them came from rural and regional areas. 60% of them told us that they needed to see a GP, but prevented, or there was they didn't access a GP when they should have. They knew they needed a GP, but they didn't go there. The reasons given were basically judgmentalism, experiences of previous poor experiences, and they feel tired of having to educate their health practitioner one more time about what's, them, basically, the individual selves. So we know it matters, and it's something that unless you've got the data to use, it's hard to I guess, make the argument to mainstream services why they're not inclusive, and it does take a lot of time, advocacy and persistence to do it.
Look, on that point, I'd like to bring in a question from the audience. So someone has asked, anonymous, sorry, I'm not sure who anonymous is, but thank you. They have asked, will SWASH be looking to expand geographically during the next survey to capture data from more vulnerable members of our community?
I'm happy to answer that question. I'm not quite sure who the vulnerable members of the community you think that we're not capturing. Maybe you mean regional. So a couple of answers to that. We did a special survey in 2018 with the Northern Rivers and Mid-North Coast. So you can go, if you have a look at that link for the SWASH report from this year, you'll find the Northern Rivers report. So we've got some data. We've also in the past done some work in the Illawarra region. So again, looking at LBQ women in that area. We don't say this very often, but SWASH is not funded. So it's run by community for community, and so we have limited capacity to do all of the things that we would very much like to be doing, including, I think, in regional work. And we try to partner with people where we can. I think that there are absolutely people missing from the SWASH sample, and we try to be really clear that SWASH is about community engaged folks. That's how we get people. So that's the people that we're going to hear from. So that's the claims that we can make. So we're absolutely not hearing from people who are disconnected from community for whatever reason.
Thanks for that, Julie. So another question that Liz has indicated she'd like to answer about how do we integrate peer workers into mainstream sexual health services? Is this something that already happens, or is checkout, trans tests, etc., held on specific days? So what would work best for our community?
Well, so services like checkout and trans tests are held on specific days. So checkout before the pandemic was every week, trans test was every second week, and so there are only specific windows that these services are able, and of course they're geographically limited by you have to be in Sydney to be able to access them. But one of the things that we as peers really are able to do to help people is to actually give people the tools to be able to advocate for themselves out when they see other services and access other doctors and things like that. Like, there's no reason that they can't take the information they've learned from these services or from themselves or from community or from however they're accessing their, sexual health information, and take that into their own doctor spaces and to advocate for themselves. And it's a really difficult thing to do, and it's an unfortunate thing to have to ask for, which is why we're, talking about things like LGBTQ health centres and stuff like that, because self-advocacy is exhausting and is tiring, but it is a way of being able to actually go out into the world and do this. You can also have people advocate for you. So whether they're professional, whether they're close friends, loved ones, things like that, to actually act as a barrier. One of the things that we actually suggest a lot on Trans Hub, which my other job at ACON is I'm part of the Trans Health Equity Division, and we just launched Trans Hub recently. And it's this idea of having a support person or a co-pilot kind of there to act as the barrier between you and someone who might be adversely affecting your mental health or your physical health in a way, who can actually stand up for you and advocate for your pronouns, advocate for your name, advocate for your health needs, so that there's just that little barrier between you and them, so you're not feeling the brunt of that effect on you always. And I think that's advice that applies broadly across the entire queer community, is take someone who actually have that fight for you, because it's sometimes a little bit less exhausting to have that fight on someone else's behalf than your own. And so take someone you trust to just be like, actually, that's not really a question that she's going to answer, or I really don't think that that's a place that we're comfortable going right now, or can you explain why you need to ask that? Like, I don't think that's a question that actually needs to be asked right now. And so if you have a look on Trans Hub, there's a series of downloads there, including things like 10 questions to ask a doctor, and they're kind of great ways of finding subtle and careful, but also really self-empowering ways to enter medical services that might otherwise feel a bit inaccessible.
Thanks so much for that. I'm just going to delve into some questions. So when people registered, they also sent questions in, and I'd like to go to some of those if I could. So the first is what the predominant misconceptions around healthcare and sexual health for LBQ women are, and how can we gain more awareness and have more conversations around LBQ sexual health when there's often so little accurate information given by healthcare providers?
That's a big question. So I think the first part of the question, the misconception thing, relates somewhat to, or directly to, the SWASH report, being that women who have sex with women, which if we actually break that down, we're talking about, in this case, we're talking about people with vulvas who are having sex with other people who have vulvas, do not get STIs, are not at risk of STIs. And that relates to also an assumption about the kinds of sex that people with vulvas have with other people with vulvas, as in a very limited different options for sex, which is not true.
That's not what our communities do.
No. If you look at both SWASH and other evidence, we do everything with everyone, actually, all the time. So I think one of the major ones is that we're not at risk of STIs, and that is incredibly problematic, because it's not true. Like, it is absolutely not true. Medically, it is not true. But also, part of the problem with it is that that is definitely an assumption that doctors make, and they don't advise STI testing, and they sometimes don't advise cervical screening for lesbian identified, women. And that's incredibly problematic, especially when we think about cervical screening is to protect us from getting cancer. And I think that what happens is it all boils down to this cultural idea that lesbians don't have sex, that sex isn't sex unless a penis is involved. And then you have medical professionals, some medical professionals, Amy Coops, I love you, you're sitting right there. You have some medical professionals seemingly agreeing with that cultural assumption by dismissing people who come in and ask for sexual health screening by saying you don't need it. And in that, it looks like the medical world and our cultural world are actually colluding to erase lesbian sex as anything, anything that has any consequence in the world. So I think there's a couple of really interesting cultural and medical things that are joining forces to make it an invisible issue, and it is
Which
not.
is completely compounded in things like cissexism and trans misogyny and biphobia and all those experiences as well, where none of these sexual experiences are real unless there is a cisgender man with a penis involved. And so you have a whole broad range of queer, wonderful experiences that aren't counted as sex and therefore aren't counted as worthy of research or risk and consideration or recognition or reward.
Yeah, and they're not getting asked about when you get a sexual history taken, when a doctor will give you a sexual health screening, and they ask what kind of sex you're having, and they ask, do you have sex with men or women? And you say women, but they don't ask any further questions. Do you have sex with people who have a penis? Do you have sex with people who have a vulva? What kinds of sex are you having? Are you using condoms and sex toys? Are you using gloves for anything? Are you using all of the different things that we can do? Never mind getting into other practices like BDSM, and never mind getting into polyamory and who the partners of our partners are and what that means, Are any of your partners having sex with gay or bisexual men? Are you having sex with gay or bisexual men? Bisexual men exist.
No.
No, I don't want to shock you. There's more than one, and sometimes they interact with our community sexually. So there's all these issues around risk and safety and screening that are just getting totally missed because no one's asking the right questions, and they're coming from, as Liz just correctly pointed out, cissexism, elements of trans misogyny, lesbian erasure, bi erasure. It's just a tangled web of patriarchy. It's just
look. Yeah, sure. I just if you can be quick. Yep.
Yeah, just want to add. I think one of the other common misconceptions, and not just around sexual health, is that your gender identity and sexuality is not relevant. And what really that means, I think, is that most doctors and healthcare providers are not comfortable talking about it. It's not that it's not relevant. That's it.
Look, this comes to another question that's coming from the audience, and we're running a little bit late, but we started a little bit late, so I might just squeeze out one or two more questions. So the questions coming from the audience. There's this idea that there's resistance from GPs and healthcare providers to providing specialised care to LGBTQ communities because the population's too small. What does SWASH data or experiences with checkout and trans tests kind of tell us about that? Is that true?
I mean, I think we can immediately say that with the clinics, the fact that they fill up so quickly shows that there's a large demand and there's lots of people. But, my areas in trans health and trans community, the percentage that is estimated of trans people of the entire population ranges from 0.4 to 4 or 5% of the population. And in New South Wales, that could be 150,000 people. So these are not small populations of people, and that is simply transgender people, let alone queer, gay, lesbian, bisexual, expansive, sexuality diverse people. So there's a lot of us, and also we're not going anywhere. We're wonderful, and so we need healthcare, and so doctors have got to step up because we're not a small community.
Julie, Rachel, would you like to add to that?
I guess just to say that I think I think there's an ethical issue here. In some ways, it doesn't matter how big or small the population is if actually what's happening is that we're not getting healthcare provided that people are needing. So, and I think it's a bit of a cop-out because what it says is you're too small to matter. And I have a real problem with the ethics around that. I think that one of the things SWASH has consistently shown is in particular areas that there are health issues, and it's not because there are women who are having sex with women. That's not what the health issue is. The health issue is, as we've already recognized, patriarchy, biphobia, transphobia, that those are the issues. And so I think there is a responsibility on the medical profession to not make assumptions. And so in some ways, if you're asking people about their sexual practices, it doesn't matter whether they're queer or straight. You can ask those questions in an open way, and if the problem is actually, as Karen said, you're afraid of what the answer might be, then that's not our community's problem, that's your problem. And so I think that's, I would also acknowledge that in my experience in medical education, doctors aren't getting any training on this, so it's also, that's an issue about curriculum.
Yeah, absolutely.
Sorry, I was just going to add on after Liz and then Julie. I just agree with you, but I was just going to be more blunt and say that I don't even give a crap if we are small. It doesn't mean we don't matter. Like, do we have to reach a certain population threshold before we start to matter? Like, that to me goes against everything that we would stand for as a minority and a minority within a minority, which is that actually we do matter. That has been part of this struggle. To be like, yeah.
Just to, I guess, come to a final question, which in some ways relates to that. There's a question that's come in about neurodivergent people and people with a disability, you know, within our community, of being able to access peer-led clinics and services like this, but, you know, that can kind of address their specific and, you know, resonate with their specific needs. How can we start supporting these communities better in a healthcare setting?
Yeah, I think, you know, with Checkout, it's ongoing. Part of the thing I love about it is that we keep moving and changing, and part of that is to do with working with a really diverse staff, which includes neurodivergent queers, and people feeding back what would work for them in that situation. So looking at different lighting, looking at different music. Like, I've had to put my foot down around a few of the lesbian musical choices that have happened in the clinic due to it being overwhelming in a sensory sense of the word, but having things like soft tactile cushions and, you know, kind of heavy rugs for people to ground them. There's all kind of different, like, small ways that we can work to make it more accessible to neurodivergent people, but then that's not a monolithic group either. So, you know, it's an ongoing process for us in making it more accessible for a range of different neurodiverse people. And we all know neurodiverse isn't monolithic in your lifespan or even in a week. And what you need one day might not be the same the next day. So for us, one way to counter that is to provide client-focused care. Our peers and our nurses are trained to respond to the client and what they need, and the atmosphere and what's happening for them, and trying different ways of communicating, which our peers go through in the training. Offering non-verbal signs to a client when it looks like they're having difficulty speaking, that kind of thing. That's just a small way that we work, but part of it is through experience, using people who have lived experience, using them, terrible Viv, drawing on their life experience, working with, thank you.
Somebody save her.
There's no saving me, my darling. But yeah, and responding to client feedback all the time. We get fantastic feedback about even the smallest things, like around, you know, the nurses, there's a examination bed that goes up and down, pretty traditional. And someone wrote and said, it'd be great if the nurse gave me a heads up when the bed was going to go up because of this reason. And I was like, yeah, and then we put that in policy. It's like, don't move the bed unless you tell the client, like, at all. Don't care, even if it's just a little bit. Policy. Don't even care if you're chatting and they seem comfortable. That's part of informed consent now. Don't put the bed up and down. So those things, they really do help. The little things matter in medical care, in my experience.
Yeah, look, thank you so much. That's excellent. And I have made us run ever so slightly over time. I'm very sorry about that. But I'm going to have to wrap things up here, which is a shame because I feel like the conversation could honestly go on and on and on. But please, you know, keep this conversation going offline. And thank you so very much to all of you for joining us out there in the ether, and I can't see you. And thank you to all our panelists as well. I'm just reminded that this is the second of 3 SWASH Spotlight Forums. So we'll be having our third and final forum, same time, same place next week. We'll be talking about alcohol and other drugs and mental health. So we'll be joined again by Julie and Rachel, back with special guest Sarah Etta, who's the chair of the Gender and Sexuality AOD Network, and Lucy Watson from ACON. Please come back and join us again. We'd love to see you, and yeah, keep this conversation going. It's really important. And for me, as someone who's coming into the medical practice, I can't tell you how valuable it is and how much I wish these conversations could be out there in the domain where they need to be heard by training doctors.
Amy Coops, just hurry up and become a doctor so we'll all just book in with you, problem solved.
If you want to come all the way to regional Victoria, knock yourself out. No.
Oh, telehealth.
Telehealth is the future.
No, I'll just text you. And get it for free. It's all right.
I have WhatsApp billing rates, Viv. Thank you so much, everyone, for joining us. And as Anna said, please register for next week. We'd love to see you again. See you all later.